Thank you so much for that introduction. My name is Ryan Greenstein. I'm the Legislative Director for the National Association of Attorneys General, or NAG. NAG represents all 56 state, territory, and the District of Columbia chief legal officers, and we're greatly appreciative of the Public Health Institute including us in today's conversation. As you may recall, for those of you that attended last year, Surgeon General Adams said in his keynote that the importance of law enforcement and public health working together on these issues is imperative to moving forward and solving this crisis. I'm glad today to be joined by two of the members of NAG, Attorneys General Yost and Jennings. I'd like to introduce them briefly, but encourage you to visit the conference materials to read their full bios and visit both of their websites. Attorney General Kathy Jennings previously served as the Delaware State Prosecutor under 3 Attorneys General. She was the Chief Deputy Attorney General and most recently has served as the Chief Administrative Officer for Newcastle County, the largest county in the state of Delaware. She was elected to Attorney General in November 2018 and is a proud Democrat. Joining us from Ohio is the 51st Ohio Attorney General, Dave Yost. Also elected in November 2018, but as a proud Republican, Attorney General Yost began his public service career as Delaware County's auditor and prosecutor, where he was responsible for taking down the largest drug ring in county history. He was first elected to statewide office as the 32nd auditor of the state and served 2 terms prior to being elected as Attorney General. Both have made combating the opioid crisis a central priority in their administrations, and we're grateful to have both of them today. So I'd like to start off today by just asking both of you to describe the role of your offices in your state in combating the opioid crisis. And Attorney General Jennings, I'd like to start with you.
Thank you, Ryan, and thank you to the Public Health Institute for inviting us to your important summit on opioids. States have a legal, political, and moral responsibility to provide for public health, and that costs money. That also means that attorneys general, as the chief legal officers for the states, have a responsibility to pursue and recover damages from those who put profits over people and who sowed the seeds of this epidemic. Delaware is proud to be part of a multi-state federal legal action against opioid manufacturers like Purdue. In Delaware, we have also sued the Sacklers, who directed Purdue's greed and avarice. And we have sued opioid manufacturers and distributors in Delaware Superior Court. As a prosecutor's office in Delaware, we also deal firsthand with the downstream effects of the opioid epidemic, including petty crime and recidivism stemming from substance abuse. That's part of the reason that I implemented internal charging reforms that direct prosecutors to rely on diversion and treatment before criminalizing the disease of addiction. We have supported various law enforcement diversion programs, such as Hero Help, that law enforcement agencies throughout our state are replicating to give people a chance to get help rather than a criminal record. And we continue to work on ways to prevent opioid abuse by making Narcan readily available to our first responders throughout our state, and also to recognize those triggers that cause people suffering from this addiction to relapse, realizing that recovery is never a straight line.
Great, thank you. Attorney General Yost.
Thank you, Ryan, and Kathy, it's good to see you. It's good to be here today for this important discussion. The Ohio Attorney General's office has done a lot of the similar things that Delaware has. I think it's also important to recognize that unlike Delaware, Ohio does not have primary investigatory or prosecutory authority. And so we have local enforcement. Our job is to support them with our labs. Now, we can be invited in by local jurisdiction and frequently are to cover a conflict or an expertise gap. And we have both prosecutors and investigators, but we can't initiate those. We have to wait for an invitation. In addition to that, we house the Ohio Organized Crime Investigations Commission, and OCIC uses local resources, local law enforcement agencies in a task force format that undertakes any multi-county, multi-jurisdictional crime that that includes organization, and that obviously includes interdicting and enforcement of our narcotics trafficking laws. Very proud of the work that they've been doing on the front lines of law enforcement. But as Ryan and Kathy have both alluded to, this is more than just a law enforcement problem. And one of the things I'm most interested in is the underlying factors that lead to addiction. When I was a prosecuting attorney some years ago, at the beginning of the opioid crisis, I had a man in my jurisdiction that was a friend, actually, and he had been a United States Marine. He was prescribed opiates for injuries he had received in the line of duty, and was a long-term user of opiates over a number of years. The doctor cut him off, and he was unable, my Marine friend, to deal with the withdrawal, and ended up serving his addiction in criminal ways. At first, stealing, and then kiting checks, and ultimately his addiction left him in a position where he ended up doing time in prison, lost everything, his family, his house, everything. So what was the difference between him and, say, Dave Yost, who had a couple of days worth of opiates after a back operation 10 years ago and didn't get addicted? Well, there's strong evidence that it's genetic. And that's why my office is funding a primary research study at the University of Cincinnati and the Ohio State University emergency rooms of their hospitals, where we are going to do a genetic analysis of 83 gene sites that are known to be associated with some element of addiction or the dopamine pathways. What we're hoping to be able to do out of this is conclude with a large, statistically significant study of over 1,500 samples, and compare it with people like me who didn't get addicted but had used opiates under prescription, to find out what the genetic difference is. So many people in this addiction crisis got their addiction through a prescription pad, through a doctor's advice, or secondarily through diversion from those things. If we could equip doctors to be able to foresee who is at risk for addiction, we'll have gone a long way towards ending the flood of new addictions and be able to turn our attention and resources to helping recovery in those who have already been addicted.
Thank you, AGOs, and especially for sharing that very personal story. I want to work off what you had said about a lot of this issue starts from the prescription pad. NAG had previously last summer written a letter signed by 39 attorneys general, including both of you, supporting the Mainstreaming Addiction Treatment Act, led by Congressman Tonko of New York and in the Senate, Senator Murkowski of Alaska, that would remove the DEA X waiver that research from our partners have shown has made it very burdensome for counties to get prescribers that are certified to prescribe buprenorphine, which is, of course, can be frustrating when there's no additional training required to prescribe these opioids. But when it comes to prescribing the medication-assisted treatment, these barriers have been put in front of practitioners across the country. So I want to ask not just about the medication-assisted treatment, but other legislative solutions as well. that both of you would like to see, either from your state house or, of course, NAG operates more federal advocacy. And I'm interested to see what other solutions you'd both like to see. And we'll go back to AG Yost on this one to start.
Well, the DEA waiver, as you mentioned, is really pernicious. Suboxone shows a tremendous potential for treating opiate use disorder. In fact, it substantially increases the likelihood of a sustained year of sobriety. And medically assisted treatment is what we call it. And Suboxone with counseling and therapy is much more effective. I've seen numbers ranging into the low 30s as opposed to more traditional counseling approaches alone. Another thing that we've talked about, and I'll pitch this over to Attorney General Jennings to talk about. I know she has been interested in the Medicaid waiver and was instrumental in getting us to a place where we didn't have this absurd 16-bed limit, or at least we have a temporary waiver of that limit for Medicaid eligible treatment.
Thank you, General Yost. And I must say your story is very compelling. It is a story that could be told by literally thousands, if not millions of people across the United States. I would venture to say in our small state of Delaware that not one family has gone unaffected by this horrific epidemic, whether it be a family member, a neighbor, a friend, a son, a mother, a father. It is rampant. And so it is incumbent upon us to help people in the most effective way possible. There were more opioid overdose deaths in 2019 than there were combat deaths in Vietnam in 2 decades. Nothing should be off the table to help people who have succumbed to this terrible disease. Addiction is a disease, and as I have said, the path to recovery is never a straight line. But there is medication that can help that has few side effects and little known potential for abuse. The only problem is that physicians had to jump through hoops to prescribe it, securing the so-called X waiver that served no clear public benefit. Whether you're a Democrat or a Republican, we can all agree that regulations ought to make sense and that we need to give people the best possible shot at surviving and recovering. That's why Attorney General Yost and I both signed on to the NAG letter, the National Association of Attorneys General letter, urging Congress to pass legislation that would remove the X waiver for Suboxone treatment. And we now know we have that on a temporary basis, but it ought to be made permanent. Fentanyl scheduling is another area where I believe legislation can assist. It needs to come up to the time when we recognize that it is a highly addictive narcotic drug. And each state is examining whether to have fentanyl listed as a higher schedule narcotic drug. We know its deleterious effects. In Delaware, we have a program called the Fatal Incident Review Team. It's a review of all overdose deaths in the state of Delaware due to opioids. And one of the many things we have learned from reviewing these deaths is the high number of people leaving prison who overdose within the first month of leaving prison. And that is because they don't know about fentanyl or they aren't used to its effects. And fentanyl is in so many different drugs now. You're not warned that it's in there. You may not know that it's in there, but it's deadly. And so it's critically important that we treat fentanyl with the seriousness that it poses. We also would like to see the federal government repeal Medicaid's Institution for Mental Diseases exclusion, which prohibits state Medicaid programs from receiving federal reimbursement for mental health or substance use disorder treatment in a residential treatment facility with more than 16 beds. As I just said, there is a temporary solution to that, but it needs to be permanent. One size never fits all. I have talked to families up and down our state, and they are begging for this kind of alternative treatment because Suboxone is great. Medication-assisted treatment is really the gold standard of the profession. But quite frankly, some people need additional support and some people need different treatment. And so we need to open up avenues of treatment that heretofore have not been open to people.
Great, thank you. And Attorney General Jennings, I appreciate you mentioning the other NAG letter we did more recently to supporting the extension of fentanyl scheduling. That was actually led by Attorney General Yost and was one of few letters that received all 56 state attorney generals' signatures. And AG Yost, I should have mentioned that one earlier, but wanted to give you the opportunity if you wanted to talk more about fentanyl scheduling in that letter before we moved on.
I'm going to rest on the remarks of my attorney.
Okay.
Well, can I at least thank you, Attorney General Yost, for doing that? It really showed leadership, and it shows the great relationship that we have at the National Association of Attorneys General, where we are able to get meaningful work done for the people we serve by reaching across the aisle and coming to common ground on important issues. So thank you, General Yost.
Thank you, General Jennings.
So I wanted to ask another statistic that AG Jennings mentioned about the death rate from overdoses last year. That stood out to me over the past few months of the pandemic is every report seems to be indicating that this year will almost for sure be the worst year on record for overdoses as well. And I want to talk a little bit and hear how the pandemic has changed how your office is approached, but also how your local partners have been approaching overdoses as well, and how that's complicated things for your local law enforcement partners, as well as just barriers for your attorneys in doing the work they've been doing around opioids.
Sure, and I'm glad you're asking this question because it is near and dear to my heart that our criminal justice system be fair and equal for everyone, and that nobody go to prison if they are not a danger to others and can be treated safely on the outside. And so, you know, it's taken a number of years. I remember talking with law enforcement agencies 5 or 6 years ago and discussing the idea of providing Narcan to first responders to include police officers. And at the time, believe it or not, that was a controversial issue. Now, all police agencies in our state want to have Narcan on hand so that they can deliver it immediately when they come to a scene where there's been an overdose. I think that should be a priority, both in the federal government and local governments as well. And I've also seen a sea change in how law enforcement itself is dealing with people who suffer from addiction and mental health crises. Several years ago, the Newcastle County Police in the county where I worked for a time started what's called the Hero Help Program. And if someone asked for help, either walked in the police department, made a phone call and said, I need help, they would not be arrested for very low level offenses. Instead, they were given a detox bed and immediately put into a treatment program. This has had a dramatic impact on not only the people who are being served, the most important is the people who are being served and the lives that are being saved, but on the mindset of our law enforcement partners, because they want to save lives. They want to help people not commit crimes and not get involved in the criminal justice system. And working together, we are seeing a rapid expansion of law enforcement assistant diversion programs across our state. I think it would be a real help if the federal government would issue grants to encourage those types of programs, because they work, they build trust, and they enable the police, who are first responders at many of these opioid overdose situations, to save lives and get people on the right track.
You know, Ryan, one of the things that is killing us in this epidemic is the fact that it keeps going on and on. My office has currently just completed a data mining project, and the graphs in it will turn your hair white, and your suspicion, at least as applies to Ohio, is correct. This will be the worst year of the opiate crisis, and it's driven. You can see the spike occur at the advent of the COVID pandemic. We currently have our lead scientist is in the middle of peer review for an article that I expect to be published relatively soon in a major medical journal. But the problem that we've got is exacerbated. We have this flood of new addictions every year, and addiction has such tenacity. There's no hard data on this, but if you talk to a treatment professional, they'll tell you that it takes, on average, 7 tries at sobriety, at treatment, before an addict is able to achieve a year clean and sober. That's a daunting statistic. And another one like it, 3/4, 3 out of 4 of the people who enter a 6-month, a 30-day addiction treatment program will relapse within 6 months of completing that 30-day program. The bottom line is we don't know how to quickly or easily repair a human mind that has been damaged by this addiction. And I don't know if we'll ever have the science to repair a broken heart. But I compare this to the analogy of a water main break downtown. We've all seen these in a big city where the water supply is massive. You know, the water lines underneath your pavement are 3 feet or 6 feet in diameter. If one of those goes splooey, you've got a huge mess downtown. The way we're treating the opiate addiction crisis in this country is we've got a water main break, and we keep hiring more and more and more people with mops and buckets to go clean up the water. But until we can repair that pipeline and shut off the flow of new water, it's a hopeless task. The brave and dedicated, empathic people who are giving care to these addicts are never going to be able to keep up with the incoming, if you will. So it's critical for us to explore new ways to stem that tide, to turn off the water main, if you will. That's partly the genetic study that I just talked about. I think another thing is looking at technology for treatment. One of the things that we know is very effective is peer involvement, peer support, which is why we have group counseling, right? Group sessions. It's one of the reasons 12-step groups work. The key is group. You meet with other people, you hold each other accountable, you support people when they're down, and you find strength in others. I'm reminded of a Czechoslovakian dissident during the Cold War who was grieving, and his priest said, find other people who are in grief, and sharing it will lighten your burden. So we have the opportunity, I think, to look at using technology to make that peer group support not happen Monday, Wednesday, and Friday at 7 o'clock down at the church, but 24/7, anywhere that you've got your cell phone with you. There's one company I know of that has a pretty well validated model and is pretty well advanced in rolling this out around the country. I'm sure there are others, and I'm not here to endorse a particular company, but I think the concept there is a new way of working, how we can bring that peer support into the addiction treatment process and hopefully slow down the number of relapses and stem the tide of new business that our caring professions have to deal with.
And you are so right. Peer support is critically important in the recovery process. As I think I've said twice before, then General Yost just said, recovery is never a straight line. I remember years ago when judges used to impose a zero tolerance for people abusing a substance, and it was the norm. Now it's never done in Delaware because we have learned quite a bit. We still have a lot to learn. But one of the most important things we can do is to provide that peer support, because someone suffering from addiction likely has a host of other issues going on in their lives. They may have been kicked out of their house. Their credit is shot. They lost their driver's license, and they often suffer from other medical issues as a result. And so with a comprehensive sort of wraparound peer support that can provide the simple answers, here's where you go, or let me help you on this problem first. We can't solve everything at the same time, but we can get there one step at a time, is a really important component of recovery.
At the same time, I think it's really important that we recognize the role of consequences as part of this journey that we're all on together in different ways. And we have a real-time experiment in Ohio. Bear with me just a second, but human trafficking is an interesting barometer when it comes to the opiate crisis and addiction in general. The reason for that is very rarely are people who are human trafficked kept in chains. We're more sophisticated in our tyranny in 2020, and the modern day slave traders, are using chemical chains. Their favorite trick is to build trust, then abuse it and get that individual addicted to drugs. And as we've all seen, when you have an opiate addiction, you'll do almost anything to get your next fix, including sex for hire. So we have in Ohio in Columbus, Ohio, a dedicated human trafficking recovery court. And women who have been trafficked and also charged with solicitation go through a 2-year program that includes everything we can come up with. We provide sober housing, peer housing. We provide medically assisted treatment and counseling and psychological support, as well as things like food and eventually access to a job. And during these 2 years, the women frequently zig when they should have zagged, and it's not unusual to have 3 or 4 or 5 or 6 or more stubbed toes and relapses in the journey. Well, with COVID, our city attorney stopped allowing most misdemeanors to be placed in the county jail for health reasons. And without litigating that particular decision, this year, we found for the first time that the number of women graduating from catch court dropped. And I talked with the judge and the staff what happened, because it's been on as they learn more and work at it and get better at it, there's always been a higher level of women, a greater number of women who succeed in breaking the chains and getting their life back. Not this year. We only had 2 graduates this year. What happened? No consequences. You see, during that first year or 2 of getting sober, getting clean and sober, having the motivation of a suspended jail sentence and having to serve a few days or a few weeks of that is a tremendous motivator to keep them abstinent at a time when their body is trying to repair itself, when the neural pathways are trying to reset to default. And until you reach that point of a year, or in serious cases like in human trafficking, a 2-year point of sobriety, the potential for relapse is so large. The consequences of court-imposed sanctions are critical as an element in helping many, not all, people who have had addiction problems succeed in their treatment program. And drug treatment courts, which I know General Jennings has in her jurisdiction, operate on a similar idea.
I agree, General Yost. I, many years ago, investigated and prosecuted a man who abducted, tortured, and murdered 5 women, most of whom were what we now believe and know are human trafficking victims. And many of them were addicted. They had had horrific lives. Many had been abused just as children, not all, but many. And, it's interesting to me because a comprehensive approach, including addiction treatment, including psychiatric, psychological counseling, is critically important. I got to know women who walked along a Route 40 corridor very well during that investigation and prosecution. And I will say, we were among the first people who ever treated them like they mattered.
Mm-hmm.
Like they mattered. And those specialized courts, whether it's human trafficking or trauma-informed courts, are really important because for the first time, many people who enter those courts are being told, you matter, we care about you.
It's important, though, that we not throw out the enforcement baby with the addiction bathwater. And what I like to say is bigger carrots, smaller sticks. But let's have both.
And on that note, General Yost, we will. I will say it has been a real pleasure to see you and to continue to work with you. And Ryan, thank you so much for the very, very good questions that you've asked. And to all the leaders who will hear our talk, thank you for the work you are doing. We all are in this together. And I think together we can come up with meaningful solutions. Thank you.
Thank you for having us.
Thank you, Dan. I appreciate the opportunity to participate in such an important event. Before I move into my discussion today, I want to convey one very important point. As a nation, we've been consumed with the coronavirus pandemic, and cases are on the rise again. Unfortunately, other healthcare concerns our community members face have not gone away, including addiction. For those struggling with addiction, the pandemic has actually exacerbated the issue or caused it to flare up again for people who had it under control pre-COVID-19. That is why it is even more important than ever to remain vigilant in terms of our COVID-19 prevention measures like physical distancing, limited gatherings, mask wearing, and hand hygiene as we approach the holidays. If we are aggressively proactive now, we can avoid draconian mandates like shutdowns that cause even more harm, such as increase in mental health issues, substance abuse, and overdose deaths. Each of you are participating today because you care about solving the opioid epidemic. So I ask each of you to please be champions in your own circles for taking these simple preventive measures to help control the coronavirus, because its devastation is immense and has many negative ramifications for those struggling with addiction. And now, moving on to my topic for today, leveraging systemness for innovation. First, let me explain what I mean by systemness. At UH, we define it as unity through diversity. It is about different parts of the organization coming together into a unified whole. Much like we are doing today by uniting healthcare, criminal justice, and legal professions to collaborate and brainstorm and come away with new ideas for addressing the opioid epidemic that harms our communities, we will work together today on this event. For the next few minutes, I will provide you with an example of how UH thinks about systemness, how we have put into action and innovated for the well-being of our community during the pandemic, and perhaps some of these initiatives can spark ideas for solutions to the opioid crisis. Over its 154-year history, University Hospitals has overcome formidable challenges. Once again, UH is in the state of transformation catapulted by the pandemic, but also re-envisioning healthcare to adapt to an industry paradigm shift, one that rewards consumerism and provides high-value care. Our goal is to make UH the most trusted healthcare provider. In fact, the pandemic has presented us with opportunities to enhance our trust relationships with the community. For example, we have conducted numerous community webinars on the latest COVID-19 statistics and information about symptoms, prevention, and treatment developments. We launched an easy-to-understand website with the latest COVID-19 news and information to supplement these webinars. We also hosted webinars for businesses and schools and provided playbooks and measures they could take to keep their stakeholders safe. This information sharing has required many within our organization to come together, illustrating systemness in action. From all of our 19 hospitals, more than 50 medical centers, and 200 physician office locations. Likewise, there may be applications here that can be used for building trust and educating the public around the opioid epidemic. For example, one of the many issues we faced in May centered around patients being fearful of returning for care when we resumed non-essential procedures following postponements mandated by the state of Ohio. National research reported that when it came to the coronavirus, consumers trusted their healthcare providers, with nurses and doctors enjoying a favorability rating exceeding 85%. It was important for us to ensure our patients knew it was safe to return for care at UH. So we created a series of videos featuring our trusted physicians to deliver the messages around actions we were taking to ensure physical distancing, cleanliness, and overall infection control. Here's an example of what we did.
When you go back to your doctor's office, the specialist that you see, and your pediatrician, things are going to be a lot different.
Our waiting rooms are going to look a little different than what you remember them to be. Our chairs are going to be a little further apart. You're not going to see toys and magazines in our waiting room. We've removed those for everyone.
All of our staff are wearing masks, and we're asking that all of our patients wear masks as well. If you don't have a mask, we can provide you with a mask when you come to the building. We'll be doing temperature checks and asking you questions to make sure that you are safe.
As you come into the reception area, you're going to see a barrier between you and our caregivers. While meeting with your physician will be masked and you'll also be masked.
We always strive to make sure that our offices are very clean. In between your visit, we will be doing an extra precaution to make sure that we're cleaning down, even more so the surfaces, the chair handles, the pens, the counters, just to make sure that you're safe.
We continue to be committed to your safety and your health care.
We understand that you still have healthcare needs. We understand that you still need to come to your doctor's office. We're here to take care of you safely.
The point of this is that trust is as much about the messenger as the message. Having a trusted person deliver the message helps move the needle toward achieving goals. Since reopening, we've seen positive volume trends, validating the effectiveness of our approach. That's why our Thrive ED program launch in May has been so successful. We have been using a trusted messenger to connect and communicate with patients who are struggling with opioid use disorder. As Dr. Jean LeCamp briefly touched on yesterday, the Thrive ED program matches patients who come to our emergency departments as a result of an overdose with a peer supporter who also previously struggled with substance use disorder. This peer is someone the patient can relate to and helps ensure the next step is in place before the patient is discharged. The peer supporter also aims to stay connected with the patient throughout his or her journey. Since launch, approximately 80 of our patients have used the Thrive ED program, with about 75% of them referred on to additional recovery supports. But we know we must continue to work every day on maintaining and enhancing this level of trust. Key attributes that will help us in this journey include being purpose-driven, consumer-focused, a high-value provider, and agile in all that we do. Let me unpack each of these for you. Purpose-driven means keeping our mission to heal, to teach, and discover central to all of our decision-making. This is why we are here. A pandemic example included standing up our hospital incident command center, where we brought leaders from across the system to quickly make decisions and cascade our directions on best treatment approaches for healing our patients. Teaching our team of 28,000 caregivers was also important, as was disseminating rapidly expanding and changing protocols, and then launching more than 130 clinical trials to discover COVID-19 cures and new prevention mechanisms. Perhaps an incident command structure could work to marshal local resources in fighting the opioid crisis. Also, as a nonprofit, our purpose is to address the needs of our community. And while we have several examples of how we partnered before with other health systems in our region for the good of our community, such as we have with the Northeast Ohio Hospital Opioid Consortium, we look forward to further giant steps during this pandemic through our collaboration with the other healthcare systems, and in particular, the Cleveland Clinic. Recently, Tom Mihalovic and myself joined and penned an op-ed where we committed to continue this collaboration in 4 key areas: battling the opioid epidemic, expanding research, improving talent recruitment, and bolstering training. By joining together, we've created a scale for impact that's not possible on our own. Consumer-focused means providing our patients with consistent quality of care and the best patient experience, no matter where they access care: inpatient, outpatient, when they call and talk to someone in our call center, or even when they schedule an appointment online. An example of this in play during our pandemic was our quick pivot to telehealth. For some time, many providers were reluctant to use telehealth prior to this event for a variety of reasons. However, during the pandemic, it became vitally important, as it was the only way for many to continue seeing patients and many patients to see their doctors. For example, prior to the pandemic, our behavioral health team at UH Cleveland Medical Center saw approximately 4,000 outpatients a month. However, that number climbed to 6,200 recently because of the widespread adoption of telehealth in the behavioral health world. It also fueled an influx of new patients who now get better access to care. While current patients typically have overcome many of the stigma associated with seeking behavioral health care, we still know barriers exist for some new patients. Some of this new volume could also stem from an increase in stress-induced issues related to the pandemic. But we do know that through telehealth, we have but one more option for meeting patients where they are. Other benefits have included a decrease in no-show rates because virtual appointments alleviate barriers to care, such as travel time, transportation issues, and parking expense. We also find that we can learn a lot about a patient and how that patient lives at home based upon what we see on the screen during a virtual visit, giving us additional information to incorporate into treatment plans. And while in-person care remains vitally important, the pandemic has taught providers and patients alike that there is great benefit in having a virtual option available. Providing high value means delivering the highest quality of care and patient experience at the lowest cost for those who receive and pay for care. UH and our industry are evolving from a fee-for-service model to a value-based healthcare model. For example, UH has been recognized as a center of excellence in joint surgery through bundled payment options and programs with Walmart and GE for several years now. Dan mentioned earlier about our launch of the UH Pain Management Institute and how that facilitated the creation of our comprehensive pain center. Not only are these great examples of our systemness in action, but it's our hope that we can create value-based models for many treatment areas, including pain management. The next concept is agility. It's what's enabled us to pivot at a moment's notice to respond to the pandemic. Our Thrive ED program provides another great example of what I mean here. We were all set to launch Thrive ED, which was designed to have the peer navigator meet our patients in person in the ED, but then the pandemic hit and we had to restrict visitors. We didn't want to delay the launch of this vitally needed program, so we created a virtual connection, quickly arming peer supporters with iPads so they could communicate with our patients in the ED. Our systemness strategy also includes 4 foundational pillars for earning trust. That being embracing a culture built on values, strategically providing an unparalleled patient experience, implementing a structure to integrate our delivery networks, and finally, fortifying our brand reputation in the community. In any organization, culture defines how we uniquely work together to support each other and get things done. And so the challenge for all of us is to think about the culture of care that we want to create. That will help us help each other in a way that yields cascading benefits to those we are here to serve. To provide an unmatched patient experience, our game changer will be to make sure our care is compassionate at every touch point, but also easy to access. I provided some examples of what we have done in this regard during the pandemic. Perhaps some of these ideas will be useful to you, but I'm also committing to you that UH will continue looking for innovative ways to enhance the experience for our patients struggling with addiction and pain. Our systemness strategy is powered by our organizational structure that maximizes our strengths as a system and better aligns UH as a whole. And just like we are different parts today coming together for unified discussion, are there other silos we could bring into the fold to be more effective at fighting this disease? Fortifying brand reputation in the community simply means practicing social responsibility. UH has made great strides in this area over the years, and we want our past work to serve as a foundation, not a ceiling. I mentioned how we have recently committed to tackling the opioid epidemic with our friends at the Cleveland Clinic. I encourage you to look at your own competitive arenas. Is there someone you could call to get the conversation started about the possibilities for amplifying the benefit in your community? In summary, our collective challenge is to leverage our current strengths so we can reimagine what healthcare can be and how we can bring about solutions. We should aim to create a treatment experience for our community members that is second to none. As Walt Disney once said, if you can dream it, you can do it. Thank you very much for your time.